when you're advocating for this, you need to make sure the tone is not about, I just need more staff. It is about having safer systems across the board. RRTs, they provide a psychological safety and clinical support that make the nurses at the bedside more confident, and they make timely nursing more possible. Having a rapid response team available that they can call at any time and not be judged leads to earlier intervention, decreased on mortalities or morbidities on patients, increased identifying deterioration earlier. Those all relate to patient safety and ultimately financially also improving.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Welcome back to the Rapid Response Run podcast, where today we're diving into a topic that directly impacts nurse burnout, staff retention, and patient outcomes. Can you guess what valuable resource might affect all three of these heavy lifters? Well, if you guessed rapid response teams, then you are correct. And joining me today to talk about this topic is a nurse leader who leads a dedicated rapid response team amongst many other specialty teams at her hospital. So Jaclyn, welcome to the podcast.
Hi, thanks for having me. I'm so excited. Yes, it's going to be great.
It's been great. I'm super excited too. It is such a privilege to talk with another rapid response leader. Like, not every facility even has the resources or administrative support for these teams. So even though I meet a lot of nurses through the podcast, I meet very few dedicated rapid response nurses and even fewer rapid response team leaders. So we have a lot in common and a lot to talk about. All right.
Yeah.
So if you are a nurse and you would like to get a rapid response team started at your hospital, or if you are a nurse who responds to rapid responses but don't feel like you have the support from admin to make the team as great as it could be, then this podcast episode is for you. Jaclyn and I will walk through how we made the case for our team, how we gained buy-in from admin, and how we continue to advocate for the staffing resources needed to sustain it. We're also going to explore how rapid response teams can reduce burnout, improve nursing retention, and enhance patient safety. These are big words we need to be using when trying to advocate, and how we can prepare for the pushback and obstacles that often come with proposing new initiatives. So whether you're looking to start a rapid response team from scratch or strengthen an under-supported one, this episode is going to be full of strategies and real stories and talking points that you can take to your leadership team. Well, Jaclyn, before we dive in, I would just like to start with getting to know you really quick. Could you tell us about your nursing journey? Why did you become a nurse? How did you end up doing the type of nursing that you're doing these days? Go ahead.
So, like every young child, I grew up wanting to be a marine biologist and trained dolphins at SeaWorld. And I held on to that dream for a long time. And so, my dad was like, hey, it might not be the most stable career, but you're really good at math and science. Have you ever thought of healthcare? My mom actually worked in a hospital, the director of medical records. And so, you have to take all those tests when you're younger to see what you match the best with. And nursing was always on there. So I said, you know what, I'll give that a shot. And I loved it. And so when I graduated nursing school, I graduated with my bachelor's and I went straight into the emergency department, right into the fire. I loved it. As a new grad, that was my jam for sure. And then eventually I made it on to a specialty team. I actually started off on the trauma team. And that's really the experience, I feel that shaped how I think in high acuity situations. And while I was on the trauma team, I advanced my education. I went and got my master's degree in nursing with a focus on leadership and management. I knew I wanted to do something in leadership and do change. And I knew education just wasn't my wheelhouse at the time. So I moved into leadership management. And then I graduated with my master's. And honestly, I went back and I'm like, if I really want to get into leadership, like what would be the most education I can get that would be the most helpful? And I found that an MBA. So I went back and I got my master's in business administration with an emphasis in healthcare management. And that really opened my eyes. Loved it. If I was ever going to have to choose between the two, I would always say go for your MBA if you're looking in leadership, because it trains you really on the financial aspect. And it's going to really shape this conversation for me today, because it trains you to know that at the core of a hospital, we are here to treat patients. Yes. But the hospital does function like a business. There has to be some way to support the system that supports the patients. And that was really what I noticed in that MBA course. And then as I graduated from there, it just was a random day. I like to say a random Tuesday. Things happen for a reason. Someone was approaching me about the rapid response team and that there was going to be a coordinator position opening soon. And they inspired me to apply, and someone took a chance on me. And that was my first leadership role, as I was the coordinator over the rapid response team. And that team consisted of 14 FTEs, 14 full-time employees that were the rapid response nurses. They are a rover unit or your rover department. So we don't belong to any unit. So we don't belong to the ICU or the ED. We're our own department. They don't take any patient care assignments. They are strictly just there to respond to anything from code blues to strokes to sepsis activations. They respond to all of it. They're an extremely busy team. And then it also consisted of 2 amazing, wonderful RN data registrars. So we actually had 2 RNs dedicated to our data mining and our data analytics, and they were my lifesavers. So those 2 were intricate in, moving forward when I'm talking on data and things. Those 2 are really key players into advocating using data. And so, we have 3 on at all times, and they're 24/7. And, those 2 teams, that's where I really, trauma and rapid response is where I really saw firsthand how powerful it was to have the right people in the room at the right time. And as we saw trauma and rapid response really having great success, we noticed that there was a need for other specialty nursing teams. And those started popping up and developing. Those teams were actually under directors of units and things like that. So they were working more in silos. And at the time that I was the coordinator over the rapid response team, I got buddied up with the coordinator of our wound care. And I was like, man, we're really on 2 spectrums, but we have the same barriers, same issues, same struggles that maybe not a typical floor unit would have. And so I advocated that all of these acute care specialty teams should be brought under one umbrella, minus trauma. They're their own beast. So they kept them themselves. But I advocated that we should all be brought under one umbrella, under a director with an A&M over each specialty team. And that's what we did. We created that position. I applied, and then I became the director over the 6 specialty teams. And that included our vascular access team, wound care, diabetes, palliative, the rapid response, and our behavioral emergency response team that handled any of our behavioral crisis in the hospital. And the majority of those programs were actually Joint Commission certified and disease-specific certification. So it was a really robust program, and we were all in place under one umbrella. And hands off, best thing that they ever did, for sure.
That's awesome.
Yeah.
And you had mentioned that there's a lot of hurdles that each of those specialty teams kind of have to face and overcome. And there are some similarities. What would you say are like the overarching similarities of specialty teams as far as what they have to deal with, if we'll use that terminology?
Yeah, I always had this famous term that I would like, you're responsible for everything but in charge of nothing. And that is like a great way to say, like, you are responsible for a lot of things that go through the organization, not just at the patient's bedside care. As a specialty team, you're in charge of that wound management. You're in charge of ensuring that we don't have any happies or progressed cappies. You're in charge of educating the bedside nurse, recognizing deterioration early. You're in charge of ensuring the patient's transported to the right place. But we are not in charge of anything in particular of making units, advocating for units to change their workflow process. So you have to adapt to your environment extremely in a specialty team. You have to adapt to what the situation is, because I can't control, the admission process of the ED, or I can't control the process of upgrading to ICU. I just have to roll with it and figure out how do we work through all of those metrics and how do we stay relevant in the hospital and show our purpose. And every single one of those teams was going through that same struggle.
Yeah, for sure. I definitely can relate to all of those. Can we back it up a little bit and kind of go through like the staffing challenge? That is just a hot topic with nursing everywhere, every department. How have you advocated for additional FTEs? Because let me tell you, 14 FTEs, that is like the dream. We are nowhere near that at our hospital. Plus data registrars, like I do all my own data. So I'm so curious to learn from you, like how have you advocated for these additional FTEs? Like how do you justify that?
Yeah, great question. And I'm going to tell you, everyone's going to have that struggle. I'm not going to lie to you. We've had that same struggle in justifying how many FTEs, you have on a team. But from my experience, I really try to ground that ask that you're asking for the FTEs or the additional staff or whatever it might be. Ground that ask in a pattern that's already being seen. Like, for example, ground it in there's delays in escalation. There's missed opportunities to intervene early. There's gaps on off hours. And use those patterns that you're seeing that you're already struggling with in your hospital. Use that as the grounds for why you're asking for what you're asking. And 100%, you need to have data trends that connects those gaps to that resource limitation that you're identifying. And really the language that you're speaking to these leaders, you and I are going to have a very different lingo off camera, right? But with your to RT nurses, like you're going to have different lingo. But when you're talking to individuals who are not as clinical forward and more financial, you really want to use these words that are going to clearly define to them what you're asking for. So things like, we've identified high-risk timeframes where escalation delays are more frequent. Here's the staffing coverage that we believe would close that gap and improve outcomes. Saying things in that matter, it's going to really align with that FTE request and that it's a safety goal that you're asking for, instead of coming like, hey, we don't have any staff, or hey, I really need this resource. You've got to make those connections.
I definitely felt so. Again, as a nurse, my heart is just, I want to do this because it's best for patients. Right? I want my patients to get the best care. But I found if I just say things like, it's just not fair that the ICU charge has to leave the ICU and go do it. It's just not good for culture. It's just too hard. It's too much of a burden. It's a too heavy lift. It's like those kind of terms, like, I don't know. It's like you're talking to deaf ears. I've had to learn, like you said, to speak the language of admin, which is not necessarily the same language of nursing. And so for my specific hospital, having to identify, here's some areas that they need to work on, that they have opportunities for improvement, that they are trying to fix these problems. And if I can offer rapid response as a solution to these problems, and not just because we deserve it, because we need it, because the patients deserve it, because the patients do, even that is not, it should be, but it's not enough. And so we do have to speak the language of like, fiscally, this is a good investment in your hospital by having these FTEs. And, it's hard because like as a rapid response nurse, I'm not billing for patient interactions. Like I can't say like, hey, I went to 10 rapids today. I'm making y'all some money. What I'm actually doing is saving money for the hospital. And so trying to like narrow down, how do we actually save money? What can my rapid response do? What can we put our toes in, like being part of improving to make things better for the whole hospital? So what are some specific things that you have kind of signed your rapid response nurses up for that have made an improvement in the facility?
So, yeah, I mean, the whole goal of, our rapid response team. So like when we first started, we were more of a reactive answer to an issue that we had, for sure. But then we did see eventually that they were helping in decreasing deteriorations on the floor. They were helping giving nurses more confidence. So, if we talk about the operational flow of the rapid response nurse, they are there. They're basically the safety net. They're the constant for the patient in the hospital. They're skilled, they're highly qualified nurses. They provide so many additional supports that you may not get with any bedside nurse. And I want to, the reason that we feel the rapid response team is so important is, nursing in the last 10 years has completely changed. Patient acuity is rising. The care is more complex, but the support systems haven't always kept up. So we are asking these bedside nurses to manage more than ever. And it's really clear that we need better safety net processes. And so their job is to, one, answer those activations. Those are our critical patients that need help now. They're there to be a support. They're there to be a resource. They're not there to take over the care and become a tornado and come in and just take over and leave. They're there to really support. And that's where you get that nursing retention aspect into how an RRT plays into it. So yeah, that's their main role, is to be there, be present, be helpful, be inclusive. And I can say for sure, it's all about how you structure your teams for success. You want those individuals on the team that have that mindset. And so that is mainly what we like to see. And that impact from having these teams is we saw less code blues. We saw higher recognitions of earlier deterioration. We saw an increase in RRT calls and a decrease in code blue calls. That's a great dichotomy you want to see. You want to see that increase in RRTs and a decrease in code blues. We saw lesser transfers from the floor to ICU, lesser upgrade transfers to the ICU. And I'd like to say all of these, when you talk the language, all of these talk to a direct dollar reimbursement rate to these financial individuals. I say it as a nurse and I hear the heart part about it. I hear like, oh man, we saved this patient's family and we saved, this patient from having to get intubated. And that is what admin hears too. However, we do have to look at it through the lens that their role is to ensure the wheels keep staying on the bus. Like they have to ensure that we are still in a way profitable. We are still a business in a sense. And their main job is to ensure resources are where they're supposed to be. So when you say that to them, do they hear the heart part? Absolutely. But what they also hear is how that directly relates to dollars and reimbursements and money cost saving items.
Yeah. Yeah, for sure.
Yeah.
It's so hard to shift your verbiage to speak that language. You had said them before, a couple of them. Can you just give us some very clear statements that I feel that nurses should come to the table being able to speak to? What are some big heavy hitters as far as moving the needle forward? While you're thinking about it, I'll tell you some of mine. Initially, we thought it was we're going to get data for how many hours the ICE, because we used to not have a dedicated team. It was we're a 500 and something bed hospital, but the ICU charge was still responding to every single rapid response that happened. And then when COVID hit, as you can imagine, rapid responses went through the roof because everyone needs to be intubated. And up to where the charge was never there. So we thought we'll keep track of the data for how many hours. That was not as convincing as I thought it was going to be. They were no, that's what they really wanted to see is could the rapid response nurse detect these patients that were declining and get them moved to maybe PCU and prevent the intubation? Could we keep the patient out of the ICU and could that be a better metric to track? Because that is dollar savings. The idea of we can't work the ICU charge this hard, well, that doesn't affect their cost benefit at all. They're still paying the nurse the same, whether she run into 10 rapids in a shift and charging. But if she's able to be proactive, which you cannot do if you're in the ICU, you cannot be proactive and charge. And so the idea of pitching the proactive side, we can help improve sepsis outcomes. We can help get patients downgraded from the PCU. There's so many things that we can do to help move patients forward in this hospital system, get them better, faster. Early identification equals dollars. Just kind of speaking that number. So you're way better at it than me with your MBA. I'm struggling. I come with the verbiage. What are some phrases that you have found hit the ears of admin and kind of prick their ears up a little bit?
Yeah. So, there's phrasing that you can say for sure. I do think that it's also your presentation and how you present the information. As a leader, you want to make sure you bring, when you're speaking to leadership, and actually I'm going to say it from a leader's perspective, when my A&Ms would come to me with a problem, I really, really loved hearing what their solutions were. I want to know what your problem is, but what do you feel the solution is? And so when a leader hears, I already thought this through, this is how I think we should pilot it, it really changes the entire conversation tone. It's not you're coming and just dumping on them and saying, fix it, right? Because they want to, for sure. But honestly, who's the best one to figure out ways to fix things? The patient or the people at the bedside, the staff, the nurses, the team, the department. Those are the ones who go through it day to day. So tell me, what do you think is going to fix it? And let me see as a leader how I can get there. And when I say about presentation, so every time I was pitching something, I really used an SBAR format. And so I used situation, background, all of that. I used a very formal SBAR format. I sent one to you. Feel free to share that. But when you present an SBAR format, and we're so used to this theme of SBAR, but it's shifted now to a leadership type of SBAR where the content needs to be. And so I think when you're presenting and talking to leadership and you're trying to advocate for something, you need to start with a problem that matters. So saying like, I just don't have staffing, that's not truly the problem. What is the problem? What is no staffing actually causing? Is it causing delays? Is it causing increased intubations? What is it actually causing? An unsafe culture. So that situation, when you're in that situation section of your SBAR, you really want to immediately figure out what the situation that's relevant. And leaders need that clear reason to care and start with the why. And then when you have and you identify what that is, it could be small. You don't need to start with something big. It could be small. Just make it specific. You want to back that up with data. So, and that could be national trends. You've seen recent studies showing rapid response teams have decreased X, Y, and Z. Somebody's already done the data for you. You can 100% use that to advocate for your reasoning on why you want this change. I will always advocate and say you should have your own data collection in some regard. And we can talk a little bit about what's the best data that I personally think helps. And then quantify what you can. So you don't need to have a full-blown dashboard that's fancy and everything. Literally, we started our rapid response team on an Excel, and then I built a Microsoft Access, and then we actually formally went into a third-party database that we collect our information. But you literally now with AI, you could collect an Excel, have your headers, pop it into ChatGPT, ask them to analyze, do they find any trends? And it does it for you. So there's so many resources out there. You don't need to sit there and be like, man, I forgot statistics that I had to take on the first semester of nursing school that I didn't understand why I needed to take it. You don't need that kind of, you literally can take an Excel form, dump it in, obviously no patient identifiers, dump it in and have it kick out and say, this is what we found. These are the trends we're seeing. And that really helps because the leadership, yes, they hear you, they want to help, but you have to advocate and justify why. Speak that language of outcomes and risk. Tell them why. Why do you need to care? Because the outcome and the risk, they understand risk management more than anything. What's the risk if we don't do this? And be very concise, be concrete. Make sure you ask and be specific about what you're saying. Not saying, hey, I think I just need a little bit of support. No, you want to say, I need at least 3 more FTEs to cover the holes on Monday, Tuesdays, and Fridays, which are my highest rapid response calls of the day. And also, per this data, is the highest incidences of code blues being called. Things like that hits because they understand it's factual, it's not subjective. You're giving them the solution that they need. And obviously, make sure you frame it that it's a system-wide win, not just a staffing win, that this is going to win for the hospital. Yeah, you're giving me FTEs, and that's obviously a win for me. But what you're going to get out of that is that ROI, or what we call return on investment. You're going to see a decrease in code blues, which is dollar amounts, a decrease in unplanned intubations, dollar amounts. Those things are all going to be a win for the hospital. And then I always say close with a really confident recommendation and forward thinking. You want to leave them thinking after this, how do we make this happen? How do I get this to this team? How do I get this resource that they're asking for? And I find it's very impactful. Tell them what will happen if they don't. Be truthful. If we do not see 3 FTEs, then we can expect this continued gross increase of code blues or X, Y, and Z. Be explicit, saying, hey, we will continue to see a decrease in, nurses coming back or nurses exiting the hospital because they don't feel safe. They don't have a culture of safety. So that's, in a nutshell, the best way I can explain how you want to have those conversations, what type of things you want to say to really engage leadership back to you.
Yes, Jaclyn, that's good stuff. So I know there's nurses that are listening that are like, okay, that sounds cool, but I'm not a data person. I'm a bedside person. I don't do the data. Yeah. I just wanted to remind us all that Florence Nightingale, who is the founder of modern nursing, she was a statistician, and she actually made waves in our understanding of germ theory with her ability to collect data. She saw the problem. These soldiers in the Korean War are getting infected. And I think that the problem is there's no hand washing. And so she's talking about it. No one's hearing her. So then without Excel, without computers, without anything that we have now, she collected the most amazing data to look at infection rates and to compare hand washing and no hand washing. If you have a moment, just Google it and you can see like the pie charts that she created to like prove her point. But because she took the time to collect the data, that's how she was able to basically shift everything that we know about germ theory and how we care for patients forever. And so I'm sure she wasn't like, oh, I love collecting data. I don't think any of us love collecting the data, but I do like getting the results from the data that helps us make a better argument so that we can advocate for better patient outcomes. So again, 100%. Excel spreadsheets make me nauseous, but I get out of bed for improving patient outcomes. I'm willing just like tough it out for a couple hours with me in Excel if I know it might mean the end result is I get more FTEs, so I can be more proactive, so I can catch those patients early. To me, it's worth it. If I can keep that end in mind, it'll get me through the slugging away with the Excel because I'm not an Excel person at all.
Yes, that's true. So, I'll touch on that a little bit because data is my thing. I love it. I have an analytical brain in that regard. And I think why data is so meaningful with decision making is because it's not subjective. The numbers don't lie. It's very clear, concise. You take the emotional aspect out of it, and I feel more confident making a decision based off of the data I've seen. So that's why it's so extremely important that we have good quality data, not just any data. Like I can throw numbers on a dashboard, but it has to be like good quality data. And I've said, you don't need a fancy dashboard. You don't need a fancy anything. Literally Excel. Even doing a Microsoft form where you do like a quick QR code on your badge and you input a couple of things after, you have your rapid responders, just input a few things. Great. You don't need to capture everything. You just need to capture what you're focusing on. So for example, if I want to focus on the increase of code blue calls in comparison to RRT calls, right? What I would probably do is I would have a quick form. And if it's the bedside RRT nurse filling it out, have a quick QR code that you tape to their badge. They scan it and they fill it out. And you don't have to have any patient identifiers. Like bear in mind, I think a lot of people get nervous that, you have HIPAA and things like that. You don't. You just need to have identifying factors in it. That it was on Monday at 19:03, then on unit, ICU bed 7. You just have to have these identifying factors so that you can see where's the code blue call or the RRT coming from, or the code blue call. Which one was it? And then from there, you develop what's that frequency of RRTs? What unit is calling them the most? What time of day am I getting the most RRT calls? And track things that happen prior to and after. When was the last time the patient was seen by a provider before the RRT was called? When did escalation start happening prior to the RRT being called? And then post, what happened after? Have somebody do retrospective audits and say, did the patient expire? Did they go home? Did they have any neurological deficits? And you will find from capturing just simple things like that, you will see trends that you can advocate now and say, hey, I'm really seeing on Wednesdays, or I like it because it's always Friday afternoons. We have higher call-offs from staffing. That means lesser resources on Friday nights. And I have more drunk people driving. I have more critical patients coming through the door. I see that all through this data. And I saw this really big spike of code blues being called on Fridays as opposed to Wednesday. And so you can now start to make these trends and saying, what's the factors on why Fridays were higher? And that is how you're going to get that win, because you're going to be able to show that actual hardcore facts, activations per units, events, code events per units. Those are all really meaningful when you're advocating for a team or an increase in team. And even anecdotal wins, like the patient who avoided ICU thanks to early intervention, that makes a difference. And when you pair those stories and trends together, you really build a very compelling case for leadership because you're showing them the facts.
Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140.
He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode.
So,
yeah,
for sure.
Just to echo what you're already saying. So when I was making the initial ask for our team, I basically was looking at a lot of data as far as like how much the ICU charge is being pulled from the unit. I was looking at how the numbers are, how many rapids do we have, how many codes do we have, what percentage of code blues happen outside of critical care, and then comparing that to national data. So I was like, our hospital's percentage of code blues outside of critical care is higher than the national kind of average. And so I think we could do better with that if we had someone who was watching this patient and catching them before they code to get interventions early on. And then, so once they finally gave me the FTEs, when I say FTEs, just one, they just let me start. And then they basically, this is a pilot program. We're going to give you X amount of time to kind of justify the efficacy of your team. So collect whatever data you want to show us it's been valuable. So man, I had to quickly learn how to collect this data. And initially my data was just like justifying our existence. I went to this many calls. I saw this many patients proactively, this many sepsis alerts, and this basically just like numbers. It was just a very simple spreadsheet with time, date, room number, what I did, outcome, like real basic. But with time, I realized, oh, this data can be more beneficial than just justifying my existence. I can learn what our opportunities are as a hospital and then be more precise with my interventions. So, okay, it looks like this floor seems to have a lot of rapids with hypotension. Okay, let's make some shift huddle information. Let's talk about hypotension, how to respond to it, how to assess for it. Like, basically, let's focus on what seems to be the issue. Or, we see a lot of rapids on night shift from this particular floor, like way more than normal, but not very many nurse consults. It's just rapids. They're not calling proactively. Okay, let's do some education for this floor to talk about the resource of the rapid response nurse, how to utilize them, when you can call. So basically, rather than just saying, I promise we're working, I promise we're using your money well, now it's like, oh, okay, let's get better as a facility. Let's change our education. Let's switch processes. Let's focus different ways. Let's shift staffing accordingly. We recently got 2 more FTEs added to our team so that I could have a mid-shifter. So we have a day shift rapid response nurse, we have a night shift rapid response nurse, and we just recently added a 10 a.m. to 10 p.m. because we saw there's a ton of calls that happen during that time. So if we're going to best utilize more FTEs, we should put them in that time frame when we have the most calls. And then when asking for that other FTE, I had to explain, we need the second person because if I had that person, I could do more proactive stuff. I could do more mock code drills, became more involved in the ER and helping with throughput. But right now, which is one rapid response nurse, I cannot do all the things that people ask me to do. I have to decline. I'm sorry I can't come see your patient proactively because I'm in a rapid response. I'm sorry I can't come move that patient out of the ER to the ICU. I'm in a rapid response. But if I had a second person, they could do all those things. So I had to keep track of how many times I had to say no or how many times there was a delay in care to prove I needed that second person. And after literally years of asking, they finally said yes. So my point is data, it really makes a big difference. Even if you don't love the data, the results I love a lot for sure.
And, just to close that out, I would say, just remember, we know because we feel it at the bedside why we want a rapid response team. But you really have to make the connection for leadership on what impact is that RRT team going to make. Saying I have, X amount of code blue calls doesn't really translate to leadership that you have a problem. I mean, we're in a hospital. That's how they're going to think. We're in a hospital. You're having code blues. But if you connect it to what you just said, we are way higher than the national average of code blue calls outside of critical areas. Boom. Okay. So there is something there. It's not just because we have a high number of calls. You have to make that connection on why do we care? Why is that a factor? Why is that a problem? And that's where you're going to see the difference. Because once you establish that, now you can show, hey, look at how many decrease of code blues I had on that day that I had the one FTE you gave me. Now look at the days I don't have an FTE there and how many code blues I have. And it becomes a little bit easier justifying more FTEs because you're showing that the impact you're making on the days that you're there is actually helping. That's the bread and butter. That's the key. You have to show the gap between the resource that you're getting and the problem that's been identified.
Yeah, exactly. Yeah. And then because I kept the data, I was able to go back and say, all right, so here's the percentage of code blues that we had before our AK team. And now we've been in existence for 6 months. There's only 4 of us, but somehow we've been able to cut the amount of code blues that happen outside of critical care in half. Let me tell you what else we did. And it's like, well, how did you do that? I think we did it in ways more, not just because we existed, but because of all of like the specific interventions we did to prevent things from happening and like kind of shifting the culture. One thing we found as we are starting out and, talking to the nurses and trying to shift the culture of like call early, call often, don't wait till the patient's blue, like call us whenever you're concerned, trust your tuition. Like we did so much rounding, more of like, we called it like socializing, getting so everyone could see our faces. Because before there's inconsistency with like who is the charge nurse that was going to respond. And we found that nurses would tell us things like we would quote it. I used to not want to call rapid responses because I didn't want to pull the ICU charge away from sicker patients. I used to not call rapid responses because the ICU charge seemed rushed. I could tell they needed to get back. I didn't want to bother them. I used to not call rapid responses until it was really bad because sometimes I would get attitude from the team in the ICU. But now, I'm happy to call early. I'm happy to call y'all because I know you're friendly. I know you don't have a team that I'm taking you from. I know that you're not in a rush. You take the time to teach us. So I took all those quotes that I heard from nurses and I made a whole PowerPoint about not just like the numbers that look better, but also the culture that has shifted and how. So when you said like nursing burnout, nursing retention, all these big, heavy hitters hospital are focused on, I could say nurses feel safer coming to work knowing that even if they're 6 months into their career, there is a nurse with 20 years of experience that they can call if they're 100 their session. There's a nurse that probably knows the answer to their question they can call and they're not alone. And that kind of stuff is what keeps nurses in this building. We actually had nurses that had left our hospital to do travel nursing that came back and discovered, oh my gosh, you guys have a rapid response team? This is awesome. This is so much, things are so much better with this rapid response team. So just like keeping track of all those little quotes and maybe not so much like the quantitative, but the qualitative data also speaks.
Absolutely. Yeah, there's definitely qualitative data that is just as important. I mean, you have to make that connection though, right? So having a rapid response team that promotes a culture of safety psychologically for the nurse to come to work directly impacts whether they want to work there, right? Then there were nursing retention. How much do we spend on onboarding a nurse? So if you can say, look, my turnover rate is less than 2%, that is significantly impactful for, our financial aspect. And to me, and all in all, to me, the RRT or the rapid response teams, they're a nursing version of a consult. And, doctors have specialists they can call. Nurses should too. RRTs give us that chance to say, you don't have to figure this out alone. We got you. We're here for you. And it's not just for the bedside nurses. And I often remind everybody, it's not just for bedside nurses. It's also for our residents. If you're a teaching facility, you really know how this impacts the residents. They're new grads. They're learning. And I've seen this beautiful relationships blossom where the rapid response teams become best friends with these residents and watch them grow up because the residents learn to call them and say, hey, should I start potassium on this feet? Shit. And the nurses say, I found this out, or they give them the tools to make those decisions and really help them along with their process and, be able to speak the attending language and things like that. So even residents are really thankful for these nurses. And when we have the rapid response team, the team is very about being together with all the units. They don't want to have this divide. They want to be inclusive. And our bedside nurses and our staff told us over and over, they felt less alone having a rapid response team. They weren't afraid to speak up because they knew someone, like you said, experienced is going to respond without any judgment. They reduced that emotional weight on that nurse, and the retention rates were better. Then we had the same situation. I had travelers that came to the hospital and were just like, I've never seen an institution, that had that. And I've worked in the private and in public sectors, and they've said, we never seen this kind of resource. It's amazing. So And, we've had nurses that have left to go to another facility and they come right back. And I hear it all the time. They're like, oh man, they don't have a rapid response team. I'm doing my own PKGs while I maintain 4 other patients. And so it just creates a better culture about these nurses and all that they have to deal with nowadays. I've been a nurse for almost 14 years. I can't imagine being a new grad right now. And my heart goes out to everything we have to know, all the documentation. Oh, and by the way, you have to do this for 4 other patients you're taking care of. So there is a psychological factor that has to be addressed and acknowledged, and that directly impacts retention, which I'm going to close the loop and say, there's your financial return on investment.
Yeah. And so asking admin, how much does it cost to train a new nurse in our hospital? And if we lose them at the 3-month mark, how much money are we losing? If we lose them at the 6-month mark, how much money are we losing? Like those are valuable questions to find out. Yeah. I also did some digging to find out what is the average cost per day to be in the ICU? What's the average cost per day in the PCU? What's the average cost per day on med-surg? And could we keep patients on med-surg and not have to move into the ICU if we could get interventions going proactively? And it is hard to keep data of things that you prevented. It really is. But we can look at least for me, as nurse consults go up, obviously blues go down. We saw that for sure. But even like rapid responses go down. Like the floors that have the most nurse consults have less rapid responses because they call us proactively. And then we never even have to involve sometimes the ICU. We never have to pull the ICU attending away or the ICU team. Just me and the hospital has worked together in this nurse consult situation to get the patient interventions that might, keep them from having to go critical care, have to be seen by the critical care team. So all that data is so important. So because not every hospital has a rapid response team at all, or a fully supported rapid response team, any advice that you would give to nurses who want to advocate for starting or strengthening one at their own facility? Like, where should they begin? Who are the people they need to talk to? What's the most valuable data to present? I know that's facility specific, but in your experience.
Yeah. I would say first, I would ask if I had, let's make this scenario. I had somebody come to me that I was in a leadership position and said, hey, I want to start this team. My first question is always going to be, why? What is the intent of the team? What would be the goal of the team? And what would be the outcomes that I should expect from this team? And that's where you have to kind of figure out where's the problem, right? And who are you talking to? So for example, if you're an ER, because I'm from ER, and, I've noticed that you're getting more and more traumas coming in, and my staffing experience level is around a year and a half. And I'm noticing that we're having increased missed activations, or we're having a delay in care. So there I've identified the problem in my own department. And I feel, based off of national trends or national published data, that having a specialized response team to go to the bedside when a trauma is called or a sepsis activation is called, national published papers have shown that improves outcomes. So there we go. I know what my problem is. My problem is we have delayed activations or missed treatments or delayed treatments. I'm going to come with the solution, and I'm going to say, I feel that based off of this information we have, the national data says X, Y, and Z, we should start small, where maybe we just have a person in the unit assigned to respond, just in their unit. You can start small because maybe the institution won't have an FTE right away to give you. But you can say, hey, when an RRT is called in the ED, the team lead in section, 2 will respond to check in with the nurse, and start small and say, okay, so they checked in. And then once you start those processes and workflows, after you get approval and, you want to go to your unit director, your unit leadership, whoever that is, talk to them about what your process is. Once you start that workflow, you need to start measuring those outcomes now. And pick something very small. Time from activation to CT scan. Okay. And you can say, start with something very small because, we're delaying in care. So you can start very small and say, hey, our time from, this to CT scan has decreased by this many minutes. Our time from this to, our stroke medications have decreased to XYZ minutes. Things like that. Start small. And then when you start to see the impact happening through those outcomes, now you start advocating for more and say, hey, you know what? I've now identified that we're a delay in getting antibiotics in within 60 minutes for sepsis. So we could probably utilize this response process we have in the ED. We could probably utilize it for that too. And eventually it's going to become where this is where volume comes in. How many calls is this person responding to? If it becomes out of their scope, meaning that they cannot control that anymore, they cannot respond while also having a team lead position, now we advocate and say, hey, we saw it with just this little minute change. If you give me this 1 FTE or 2 FTEs or 3, I can have coverage at least from 11 a.m. to 11 p.m. at night, which is my highest census time. And you want to start don't go out. And I'm going to tell you the quickest way to end a conversation is don't go out straight out the gate and say, hey, I need 7 FTEs for days and 7 SEs for nights. If you don't give it to me, then it's not going to happen. You want to start small and building because you do have to show proof of concept. We do have to show that there is a return on investment. There is an ROI. So just start small in that capacity and build onto it. And eventually you are doing great. You have a rapid response team in just your emergency department, right? And you're showing the trends and the greatness that you're doing in just the ED. Now you look outside and say, hey, ICU, how are you doing? And I guarantee you, before you even have to look out, leaders talk to each other and they find out oh man, the ED, their antibiotics median time is 38 minutes. Mine's an hour and 27. How do they do that? And that's where the conversations start to grow and you start to make it very well known what your process is. So that's the best advice I can say. Start small, build on top of that. Don't come out of the gate swinging hard because you kind of lose traction at that point.
Yeah. And then just to add to that, you had mentioned a couple of these, but there's those national reportable metrics, time to antibiotic, door to needle, time to cath lab, are they implementing the sepsis bundle? What is our compliance with implementing the sepsis bundle? Maybe we get them great in the ER, but then they go on the med-surg floor and it's just not well implemented. Or
100.
What about inpatient sepsis alerts? How do those patients fare? What are some things that as a specialty team we can latch onto and make an impact? Where could we step in and really, move the needle in the right direction? And those are the things I feel speak the best to admin because they're we want to be the best. We want to have these metrics reported that are awesome numbers. We want to have great door to needle times. We want to have great door to cath lab times. So if we can be a part of making that shift, then I think admin might be more willing to give you the FTEs that you need.
You hit a great point because when I say collect data, right? I would always tell you collect data that's already been collected prior to your arrival. So these national benchmarks are great places to start. If you want to advocate for an RRT team, pick a benchmark that is being impacted that you think the rapid response team, whether that is your stroke benchmark times or your sepsis benchmark times or even the American Heart benchmark times for code blues, pick something, pick a few of those, gather that information and then implement that change of a rapid response and then measure that after pre and post. And that's how you're going to get that significant information that's going to be the most impactful for your financial team.
I love it. So Jaclyn, as we close, I just wanted to go through and just hit these topics real fast to summarize. How do rapid response teams reduce nursing burnout, improve nursing retention, and elevate patient safety? Just give me a quick run through so we can get it ingrained in our hearts and be ready to regurgitate it back to admin to advocate for rapid response teams.
Bottom line is when you're advocating for this, you need to make sure the tone is not about, I just need more staff. It is about having safer systems across the board. RRTs, they provide a psychological safety and clinical support that make the nurses at the bedside more confident and they make timely nursing more possible. And so I do feel that nurses having the option of, choosing to speak up and being judged or staying silent and taking a risk creates a patient safety issue. And so having a rapid response team available that they can call at any time and not be judged leads to earlier intervention, decreased on mortalities on patients or morbidities on patients, increased identifying deterioration earlier. Those all relate to patient safety and ultimately financially also improving. because we're not having unnecessary clerical treatments now or unnecessary upgrades to ICU. And then having that psychological safety that the nurse knows that they can come to work and man, they may get their butt kicked today, but they're going to have somebody there that they can call and just, I don't know what to do here. Just having that available to you creates, whether they use it that shift or not, creates a psychological safety, a culture of safety for them that makes them not want to leave. That every organization has that same option for them. Speaking from someone who's worked at multiple places, I can definitely say the facilities that have an option where I can call and feel safe calling is really, really highly valued. And then, burnout and asking nurses to do everything is going to give way at some point. It's not sustainable for our nursing culture anymore. We need to use rapid response teams and other things like that as a consult for nursing, and it's okay to call. And that it's encouraged to call and really having some check-in moments and education for these nurses and asking how they're doing. Do they need help or things like that is going to really impact burnout because we cannot sustain the requests as nursing is changing today with documentation requirements, state regulations. I can go on and on about the new world of nursing. It won't be sustainable unless we build those support systems for them.
Amen. Well, that is a great point to close. Jaclyn, thank you so much for sharing your experience and all of your leadership verbiage with us. I hope the nurses were actually taking notes. This is the way we're going to communicate to admin because, like we said a million times, rapid response teams don't just improve patient outcomes. They also protect nurses. They also strengthen the clinical environment and support long-term nursing retention. But, change doesn't happen by accident. It's going to take strategy and data and relentless advocacy to build something that's going to last within your hospital. So if you are thinking about starting or strengthening your rapid response in your hospital, I hope you're taking these notes, taking these insights to use them as a foundation. Learn to speak the language of patient safety and staff well-being, not just complaining about staffing. And don't be afraid to push for what your team truly needs and ultimately what your patients really need, right?
Absolutely.
All right. So Jaclyn, thank you so much. I wanted to add in the show notes, I'll have a link to this SBAR guide that Jaclyn made. It is really, really good. I would say download that baby and start knocking out all the questions that he has on there. It really will guide you as you prepare a presentation for admin. Jaclyn, this has been so helpful. I wish I had met you before I started my team. I think I said I skipped a bunch of hurdles and just jumped right to the meat. But thank you so much for your time today and for sharing your wisdom and your insight and your heart for these specialty teams. Seriously, I can't thank you enough. This is a really great conversation.
Absolutely. Thanks so much for having me. And I hope this helps anybody because go specialty teams. We are the future.
I love it. Yes. All right. Well, thanks for listening, everyone. As always, stay safe, stay supported, and keep fighting for the kind of care that your patients and your colleagues deserve. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as The Rapid Response RN.